4, 3, 2, 1. Sir, we are live now.
Thank you, Maharshi. So, welcome everyone. And in today's session, we are going to discuss some interesting cases which we came across in last few months, and we got puzzled and confused about the management. And then we managed them somehow. We have experts today, Dr. Kapil Gangwal from Jaipur, Dr. Rudraprasad from Bangalore. They both are very close friends of mine. Dr. Sanjay Sarup from Delhi is also another participant, but he's busy and he would join in the course of meeting and will take his help as well. We have Dr. Manish Mehta, our pediatrician, a very I would say very talented and quite a helpful pediatric colleague who has helped me in infection. Manish, are you here? So he's in Surat for another meeting, but he would jump in anytime. So let's start today's meeting. And this will be interactive cases, so you can interrupt us, and I will moderate this session. Thanks, Kapil and Rudra, for your time.
A very good morning, everyone. Am I audible?
Yes.
So the first case for today is a thigh abscess in an infant, which we found as an atypical situation. So a 10 months old boy, he presented with a swelling over the anterolateral aspect of the left thigh since the last 3 months. He had a history of prior vaccination at the age of 6 months, and followed which he developed the swelling 1 month after the vaccination, and which the patient also got aspirated elsewhere. However, the swelling has increased again. On examination, the swelling was fluctuant, non-tender, and there were no signs of overlying cellulitis.
So, like, we inquired the history, and the child had vaccination, 6 months DPT vaccine, and he was okay. And 1 month later, this child developed this swelling. So it was actually difficult to believe that this would be. We sometimes see post-vaccine hematoma and might get infected, but this was not the case. The swelling appeared a month later, the vaccination thing, right, me?
Yes.
Yeah.
So how would you like to approach this? What would be your next step of management?
So can you go back to the photograph?
Yes.
And Kapil, if with this history, I mean, what would you like your fellows, would like to tell fellows, and what are the possibilities we are looking at?
So, yeah, Maulin, so I think the first thing that one really needs to rule out is infection. So, I think I would keep that as one of the top possible diagnosis, and it's atypical definitely because, it's a month out from the vaccination, and I believe there's no history of any fever or or any kind of inflammatory signs there, right? So, but still, you can get sterile abscesses. So that would be one of my first diagnoses that I would work for. I would get some labs. So standard CBC, SR, CRP, blood culture, and do a X-ray, and then ultrasound. And if there's collection, then try and aspirate it, send for culture. Right. That's how I'd proceed.
Yeah. Rudra, do you want to add anything?
Okay. Am I audible?
Yes.
Okay. So in this case, as you said, the history is very typical of an injection abscess, history-wise. But of course, I can't think of any other condition. Especially, the only thing is whether it is a simple abscess or something going on deep is another issue. For example, osteomyelitis.
Yeah.
So I would get an ultrasound scan first because it is non-invasive. So,
Right.
so
So
ultrasound
only-
scan, definitely the appearance of the fluid inside will have some idea whether it is a transurate-like thing or exudate-like thing. And then probably ultrasound guided aspiration I can do as a diagnostic tool. But of course, after the ultrasound scan, I would get blood investigation as discussed by Dr. Kapil. And then probably we can proceed.
Yeah. So on the first go, I also thought that this would be a post-vaccine injection abscess, but the family was very clear. Usual history is there will be swelling, child would cry, and then gradually they will see the cellulitis and redness and tenderness. Here the history was that post-swelling 1 week, 2 weeks, 3 weeks, everything was okay, and then they gradually found a swelling which is increasing, which is not very tender, and mother didn't have much problem with diapering, and there was no redness. So as Kapil said, sterile abscess can happen. So that was another thing we thought. Yes, Meet, take us through the further investigations.
Yes.
Anyone else want to comment? Then can raise the hand. Yeah, Meet, go ahead.
So our first, what we did was we got the X-rays done. We got X-rays of the both lower limbs, the spine, AP lateral of PBH AP and a troglateral. And there were no obvious signs of any bony involvement. As we can see in the image on the left femur was appears exactly the same as the right. There's no sign of any cortical involvement.
I mean, we were not expecting anything to come on X-ray because it needs about 40% bone destruction to appear on X-ray. But if there would be some small lytic area or periosteal reaction, it would have alarmed us. Yeah.
So our next step was we got a USG done, and the sonography revealed a liquefied abscess in the intermuscular plane, which reached up to the anterior femoral cortex. And there was no evidence of subperiosteal reaction or any cortical erosion. Blood investigations were also nearly normal. The total count was around 12,000 and it's predominantly lymphocytic.
Right. So now how would you, Rudra, how would you treat this? Ultrasound shows an abscess not going through the periosteum. It's all muscular. What would be your usual approach of treating this? Rudra, you are mute. So can you unmute yourself?
Sorry. Yeah, my approach will be definitely because there is an abscess, we have to do some kind of intervention. We want to know what's happening inside. Of course, what about the bleeding parameters? Did you do any bleeding parameters investigation?
Yeah, so
No,
we
normal.
did that. APTT and INR is normal. Chinmay is asking CRP. CRP was around 10-ish, so not it's equivocal, mildly elevated. Normal range is less than 6.
Yeah, if the bleeding parameters are completely taken care of, certainly I would like to take the child to anesthesia and then put a needle first and aspirate it, and then depending on that, probably I would do a IND, intra incision and drainage, and then we'll just take it from there. Because there is no cortical erosion, I don't think so we have to touch the bone. A simple IND is what is my thoughts on this.
Right. So and the radiologist was quite saying that it is purely abscess with moving and not an aneurysm or any bone muscle tumor thing. So it would be wise to put a needle first, aspirate, and if the pus is coming, then you go ahead with it. So Chintan is suggesting MRI of lumbar spine, but we got X-rays, Chintan, and X-rays were normal. And on ultrasound, the abscess was localized to thigh. It was not going above or as we see sometimes this cold abscess trickle through. So it was not connected. Yeah.
Okay. And what about doing an MRI of the thigh? Apart from the USG that you have got,
The MRI I would do if I'm suspecting something other than abscess, but looking at all these parameters, this is a simple abscess. You know, doing an MRI in a 10-month-old baby would need anesthesia again. So I think doing an MRI. I mean, we have treated so many such thigh abscess. We don't do MRI, right, Kapil?
Yeah, so Maulin, having heard what you said, I would still be inclined to at least recommend a MR screen just to rule out osteomyelitis, because sometimes the bony changes, like you said, don't show up on the X-ray. And when you go in, so there are two choices. When you go in, you feel the periosteum, and if you feel that it's breached or it's thickened or it appears that there's some pathology going on there, then you go inside the bone, you drill it, and you see right with your eyes. Otherwise, I'm usually inclined to get a MR screen just to rule out osteomyelitis, because like you said that you treated so many abscesses, and we've all seen that sometimes just an abscess you treat and you can miss osteomyelitis.
That's right. So fine, that would have been a good idea. So now let's assume that once we aspirate and we have pus, and as we drain or we done the IND, what you will send that for? What investigations you would like to do from that abscess tissue? Kapil.
So
do you send for bacterial culture and
So I typically, any aspirate that I take, I'll send a sample for a gram stain. I also send it for AFB. I'll send for a routine swab culture. I send a bacterial culture. I will. I typically take some tissue, send for a biopsy also. And if it's suspicious for tuberculosis, I typically also send a sample for a TB PCR. So that's my standard set of investigations on any aspirate that I take. Yeah,
that's right. Now, we would usually, when we are suspecting post-vaccine abscess, then we do everything what you suggested. But sometimes we miss on, sending gene expert. Let's first like to see whether AFBs are seen, and if biopsy is showing something granuloma, then we might go further. We'll ask them to keep that for culture. Right. So, Neeraj, just show what happened further.
Yes.
Dr. Sriram sir is here, even though he had a bit viral illness. Thank you, sir, for being here.
Thank you.
Yeah, and we'll take your help. I'll involve you in your interaction, please. Yes, Meet.
So the next step, the options that we considered were either needle aspiration or an IND. So this is what we performed. This is an intro video of the same, where we could aspirate this thick liquefied pus that was seen on the USG. So as Suraj discussed, how would you like to investigate the sample further? Send a bacterial culture, gram stain, ZN stain. Is there anything else that you would like to include?
Yeah, so if we drain, we must send it for biopsy. That's what Kapil said, and that's right. Rudra, anything else you would like to do from this sample? I think what we do, right?
Yeah, it's the same thing. Only other thing is I would discuss with I would discuss with my microbiologist, because this is something like an antibioma, typical that it gets sealed off from the rest of the tissues, and the abscess continues. That's why we don't get all the typical markers of the inflammation, infection positive, like total count and rest of the things, ESR, CRP, everything. It just gets encapsulated, the abscess. We have seen this. We have seen this similar situation. Only thing is the culture, because most of the time these kids before coming probably would have received some antibiotic by the pediatrician. And then if they suspected, so only thing is if there is a need for extended culture where they wait for another additional 3 days, 4 days just to isolate the organism, maybe ask for, maybe thought of. That's the only other thing I would ask for. Otherwise, more or less the same thing, whatever we discussed till now.
What antibiotics you would give to this child post-operatively by the time the reports come?
See, now in our hospital, what we are doing is a standard ceftriaxone, which is a broad spectrum. Of course, even though it is a third generation, the reason is we get the hospital supply. I think any of these
Cephalosporins
gram-positive coverage antibiotics, like this ceftriaxone and cefuroxime, and even this amoxicillin with the clavulanate is also a good antibiotic locally, which is I have seen. So these are the antibiotics what we consider.
Right. Now, so we send this and yeah, Meet, move ahead
Yes.
and show what came.
So the
So
cause.
like we sent this and the AFB was positive. AFB were seen, and then we sent this to our pathologist, I mean the pediatrician, and the biopsy will also show some granuloma, which Meet would show. And he said this is a very common phenomenon. This is just an atypical mycobacterium, which we see in a lot of patients, atypical mycobacterium. And then you don't need to give AKT, you just give the second line drug, that is clarithromycin. This would resolve. So this is a very common thing they are observing after DPT vaccination. There is some contamination of atypical mycobacteria, which would give you a cold abscess. So Meet has done a lot of literature review, and then we extensively discussed with other ID colleagues as well. Meet, please take us through.
Yes, sir. So the causes that we thought of were could be a bacterial infection, but there was no fever or tenderness over the site. But we would still send a gram stain for the same. As Sir mentioned, it could be a post-DPT atypical mycobacteria, a post-BCG atypical mycobacteria. For both of them, which as we detected that AFBs were found in the ZN stain, or it could be a TB cold abscess. So on doing a literature review, this was a paper which was a case series of 3 patients, and they found that in children who had been given BCG vaccination. So at that point, BCG and DPT, the initial doses when they were given together, they got exchanged. BCG and hepatitis B, they got the sites got exchanged, and BCG was ended up not giving in the thigh, that is in the as an intramuscular injection. So what that led to was a BCG induced cold abscess. For all the 3 patients, they needed some sort of intervention, either a needle aspiration or a surgical drainage, and they were then treated with AKT. And when found atypical, as in the first case, clarithromycin was given. They also performed a study on the type of bacteria that it was, and it was found to be Mycobacterium bovis.
But in this case, we inquired with the pediatrician, right? And there was no, the BCG was given in the arm, left arm. So that was not the case in this patient. We inquired specifically, and they know it, yeah.
This was another published case report of an isolated cold abscess of the thigh in an immunocompetent infant. This quite closely resembled our case, as our child, the patient that we had was gaining weight adequately. He did not have any signs of being immunocompromised, and no repeated infections or anything. So in this patient, he developed a swelling on the thigh 8 days after the DPT vaccination. His counts were nearly normal and predominantly lymphocytic. The X-rays were normal, but the ZN stain had detected AFB, as was in our case. And on further doing a gene expert, they found that it was Mycobacterium tuberculosis. So this resolved only with only AKT was given in this case, and it resolved after 6 months. Another case from CNBC in New Delhi. This again resembled our case where they first they started with an AKT, but since the swelling persisted, they performed an IND, and then after giving an anti-gravity drainage along with AKT, the swelling resolved within 6 months. So in cases where there is AFB positive, we have two main differentials. It could be a mycobacterium TB or it could be a non-tuberculous or the atypical variety. The way we differentiate between these two is by using a gene expert.
So when there is a cold abscess in thigh, the message is only ZN stain is not adequate, because ZN stain will show acid-fast bacilli, which can be because of Mycobacterium tuberculosis or atypical mycobacterium. The treatment of atypical mycobacterium is oral clarithromycin for a period of 2 weeks to 3 weeks, while the treatment of Mycobacterium tuberculosis is AKT for 6 to 9 months. So gene expert or the PCR is the differentiating feature between these two. And both of these, even for histopathology, they will show some form of granuloma. So gene expert is critical in this patient to define whether it's a tuberculous or it's an atypical infection. And yeah, me show further.
So as was in our case, the AFB was detected, and on further doing a gene expert, the Mycobacterium TB was detected with no rifampicin resistance, and this was the granuloma that was seen on histopathology.
Yeah, so this is one point which we learned, that an cold abscess in thigh after vaccination can happen as in contamination of the fluid of vaccine, and it can be an atypical infection which needs only maybe aspirate followed by oral clarithromycin. And if the gene expert is positive, then you treat it as a tuberculosis itself, and you have to give oral AKT for 6 months. And now giving AKT in as a 6-month-old boy, we should refer them to pediatrician or ID specialist. So your comments on this, Rudra?
No, one is, I think it's a good case, certainly a very rare presentation. And I was thinking of the message, what to give is an atypical presentation, think of atypical bacteria.
Yeah.
Because it was the atypical presentation. It was not a typical presentation for an abscess induced by an injection.
Right.
Number one. And then always try to get some curettage and some soft tissue for histopathology, because you're showing the histopathology slides, obviously you would have taken some soft tissue.
Yeah.
Was there any granulation tissue which you could see it, or just the scraping of the wall, what you did?
Yes, that's what we do. We just scraped the wall, scooped the wall, and cleared till we saw the clear muscles underneath. Just make sure that it's not penetrating to the periosteum. It was extra osseous. And then we just close it with a cotton, gauze piece in between so that it would drain from that. But it was not looking like a typical tuberculous thing, but it was thick abscess, which would have anyway formed because it was long standing. So this is what I learned. If it is a cold thing, it's not very warm. The bacterial abscesses are warm, child has fever, irritable. But if child is not irritable, just swelling is the complaint, then you just don't get only AFB, do gene expert. That's an advice. But that differentiates between atypical mycobacteria. Our microbiologist also told that they see a lot of atypical mycobacteria contamination in laparoscopy patient and C-section. The water they use to clean the laparoscopy instruments, they may have atypical mycobacteria colonization, and they just give oral antibiotics. They don't need to sort of give AKT, but they would show AFB, and we may mistake it for a pure tuberculosis, and we post them for oral AKT for 6 months, but that's not required in cases of atypical infections. So that's the message. Kapil, your quick comment, or Dr. Sriram, and then we'll move on to the other case.
Yeah.
Nothing special. Yeah.
Yeah. Kapil, anything?
I agree. I mean, very interesting case and atypical presentation. And I think the message is that we need to think about tubercular infections and atypical infections, especially when the picture is not matching with the acute abscess presentations like we're all familiar with.
Deepak is asking, what are the objective evidence for atypical mycobacterium? I think I just talked to my microbiologist yesterday. Said atypical mycobacterium are AFB positive, granuloma on histopathology, but they are gene expert negative because their genetic structure is not showing up on PCR. I think that's the thing. And he is going to provide me some more literature and I'll pass on Deepak. But I think atypical infection is more common than our tuberculous infections. Yeah, let's move on to the next case. No, Tashfeen, color of pus, I don't think it would show anything. It can be same color in all the 3 types of infections. Let's move on to the next case. Yeah.
So we had a 13-year-old boy who sustained injury to the right forearm while playing. He had a slip and fall, and he presented with complaints of swelling, deformity of the forearm, swelling, and he was not able to use them. So these are the clinical pictures. Here we can see the obvious deformity, and he had a abrasion over the dorsomedial aspect of the forearm. The radiographs, these are his radiographs, and here we can see the AP and lateral views showing distal third fracture, both bone forearm fracture. The apex is dorsal, denoting a pronation injury. So now, yes.
Yeah. So Kapil, how this 13 years old, closed injury, abrasion, and how would you, what would be your plan? Can we go to the X-ray, Buddha?
Yeah. So assuming circulation and all is okay, I think the skin's intact. It's just an abrasion. So first thing is to attempt close reduction. And so I don't typically pronate, supinate these. I just give traction and give some pressure to straighten the bone out, pull it out to length. And then see if the alignment is okay. I'd probably just splint it. It's a distal third forearm. 13-year-old boy is a little out of range for accepting too much malunion, but that would be my first step, to do a close reduction and a splinting.
So you would like to conserve this fracture. Yeah, Rudra.
Yeah, I mean, looking at the age of the child, probably I'm more leaning towards the fixation in this case.
Yeah.
Especially because the radius is the one which is going to decide the outcome, as I have seen. So probably my take on this, as Dr. Kapil discussed, of course, I will see the reduction under GA, and most likely, probably, I feel that I'm going to fail only for the conservative management. So I would plate the radius and probably nail the ulna. That's my choice.
The other thing is concerning with the canal of radius is also very narrow, I mean,
that's why I tend to plate them, because plating gives a very accurate reduction for the radius. The moment I reduce it very accurately for the radius, the ulna falls back, and then probably what it needs is either conserving the ulna or nailing the ulna.
Only, the worrisome issue was in abrasion, and at places, abrasion was a bit hot also. So that was the only thing, but of course we can take care of that, and we can do plating from the volar approach. Anyone else, any other? So there can be either we can conserve or we can plate, or we can nail, or we can do hybrid, one radius plating and ulnar nailing. Any other thought from anyone? So, anyone for nailing this fracture? Kapil.
Yeah, you could put a intramedullary wire or a thin flexible nail. It's challenging to get it into the radius, especially if you take a lateral entry like we're used to. So you have to take a dorsal entry to get into that, and that's a little problematic with the tendons. But I've done that, and since the canal is narrow, I'd probably just choose a K-wire rather than a flexible nail. So you can take a 1.4 or 1.6 wire, and maybe just to get the alignment, that's possible. Yes.
So can you hear me?
Yes, sir.
Okay.
Suddenly, yeah.
Rudra, can you hear me now?
Yeah, I can hear you now. Suddenly we lost the
Okay,
voice.
so connection was lost. Fine.
Yeah.
So I missed what Kapil said. The nailing would be.
Yeah, I'd take a dorsal entry rather than a lateral
okay.
entry,
Yeah,
because the lateral entry tends to translate the fracture. So if you take a dorsal entry and I would probably keep a thin K wire, like a
Right.
1.4, 1.6 max. That should, just to get the alignment. And sometimes if the reduction is difficult, you can try like an intrafocal entry and, try and angulate the fracture. All depends on how it pans out once you try the reduction.
Yeah, Goda, please take us through the case and show what we did.
So our thinking was, could we conserve it? Can we conserve it? Was the first question. Is it amenable for K-wire fixation? Was the next question. And can we safely nail it? Or should we consider plating? So we went through the literature. This is a review article by Jeremy et al. And they've gone through various literature, and what they've said is adolescents have less remodeling potential and the non-union and malunion rates are very high. Hence, at this age group of 13 to 15 years and above, surgical intervention is a better option, and there is a paradigm shift towards surgical intervention in these cases. So now surgical intervention. So the plan was whether we have to plate it or nail it. So this is a comparative study of intramedullary nailing to plating. Here 31 patients with both bone forearm fractures were managed. 19 patients were nailed, intramedullary nailing was done, and in 12 patients plating was done. The conclusion was that in this series was I am nailing for a length stable forearm fractures and skeletally mature patients was effective treatment compared to plate and screw. That is because IM nailing has smaller incisions, shorter duration of anesthesia, limited soft tissue dissection, and excellent recovery of range of motion, and it is easier to remove the hardware later on. Whereas in plating, we do get good anatomical reduction as well as restoration of radial bow. It's not the magnitude of the radial bow that is restored, but the location of radial bow was better in the plating group. The complications were higher, like infection, longer operative times, and there was difficulty of hardware removal and refracture following that. But functionally, the range of movement was similar in both the groups. So this suggested that intramedullary nailing is a better option. And then which approach was to be taken, whether it was a radial or a dorsal approach. So this was a paper where 245 fractures and 237 patients were reviewed. These patients were studied, and dorsal approach was used for 201 fractures and radial approach for 44 fractures. And they have found that this paper says that for distal third fractures, a dorsal approach is easier to negotiate the nail and it gives a better reduction. There is a risk of EPL rupture, and we have to protect it carefully. So in this fracture, with a lateral entry, it would be difficult to negotiate the nail, and there'll be high chances of this tens nail abutting the cortex of medial cortex. So a dorsal entry would be definitely a better option. So we went ahead and have done our dorsal entry, reduced it dorsal entry and passed a tens nail for the radius. And for the ulna, we have just distal to the olecranon physis, we have passed the nail, reduced and passed the nail. This is 1 month follow-up. There are signs of union. We have achieved good reduction. So the takeaway message from this take-home message is surgical intervention is a better option in adolescent forearm fractures, and intramedullary nailing has more advantages. Dorsal approach is good for distal third fractures. Only thing is we have to keep in mind to avoid injury to the EPL. Thank you, sir.
Yeah. So the Goda is very nicely, summarized everything. My previous practice used to be the typical lateral entry, safeguarding the superficial radial nerve. And even though I have achieved the reduction, sometimes as I negotiate the nail further, the fracture would move. And, the nail is bent. And so that will itself will move the fracture. So that's an issue. So this dorsal entry is good. While you maintain the reduction, you can easily negotiate your nail and the fracture would not displace due to the nail. The only thing, EPL injury, some people have bent the nail up and they have kept the tip outside the skin in order to the pointed part of the tens would not touch the EPL. But what you can do is you can make your entry little broader and your ten should rest on the flare of distal radius. And you go over the Lister's tubercle and go between the tendons, and that would help avoiding injury to that. So that's the point. And we went through all this thinking process, and finally we did this. Any comment, Rudra?
Yeah, one comment is the reduction techniques, because if you pass the nail first in the radius, it tends to become translated and it may not give a very good reduction. That's one thing has to be kept in mind, especially when you're dealing with the lowermost 1/4 fractures and your segment of distal hold is only very small, especially you're bending the nail and whether it's dorsal or lateral, wherever you're going. So that segment decides the reduction many a times. So what I found was simultaneously pass the nail and not completely into the shaft, but hold on and reduce the ulna and get that alignment. And then you have to play between this reduction during the procedure. That's one important advice, what I have experienced. But of course, in this case, the distal most element was quite satisfactory, so you could get a good reduction. Otherwise, more distal the fracture is, I tend to plate them. But it's a good paper.
Our practice is to fix the unstable one first, because many a times it had happened so that you fix the ulna and the radius is translated, then now radius will not move.
Yes.
So you align radius, and as you said, we don't have much hold over the distal fragment. So you have to give intraosseous pressure and try to align the proximal fragment of radius to the distal fragment. And then your fellow would negotiate the nail gently,
Yes.
otherwise it will give. So it needs a bit expertise.
Yes.
You cannot do alone. Maybe the trauma surgeons might be doing, but it's a challenging fixation.
And because the EPL especially is discussed, because if you keep on poking repeatedly, especially with the bone awl, that's when you can really damage, not with the nail.
Yes, Tushar, I'm also going to try distal entry ulna nail, but this was very low ulna fracture, so I wanted to start proximally. I would do in a mid shaft or proximal ulna fractures a distal entry, but for this it was proximal conventional entry was good. Let's move on to the third case. Huda, who is presenting it? Yeah.
Okay, so the third case for today is an infantile shoulder dislocation in obstetric brachial plexus palsy and the management dilemma that we faced. So we have a 4-month-old boy. He's a known case of right-sided brachial plexus palsy, Naraka's type 1. This was his HSE AMS score at presentation.
So Naraka's, for those who are not aware, Naraka's 1 is purely C5-6 palsy. Naraka's 2 is 5, 6, and 7. Naraka's 3 is panplexopathy without Horner's syndrome, and type 4 is panplexopathy with Horner's syndrome. So Naraka's 1 means we were dealing with C5 and C6 purely, and HSCAMS is Hospital for Sick Children Active Movement Scale score, which is in 7-point score, while 5, 6, 7 is anti-gravity movement, and 1 to 4 is different categories of movement in gravity. There's a spontaneous movement of an infant which is plotted. That's we use for brachial plexus.
So,
Yeah, Mehta. So
if we have a closer look at this, we can see that shoulder abduction, shoulder external rotation, and elbow flexion are nearly absent in this patient. And elbow flexion, there were flickers of contraction, but 1/7. And we can see on the image on the right, the patient has a deep crease on the right side. This is a static video of us trying to elicit the movements. And you can see there's some abduction, but the child cannot perform movements at the shoulder. Abduction external is not there. So with this score, our static examination revealed a passive external rotation, which when we tried to do it a little more aggressively, it was painful, and the child was comfortable only with 10 degrees of passive external rotation. Active external rotation could not be performed. The arm was towards the internally rotated. It was -20 degrees. There was a short arm segment and a deep anterior crease which was present. And wrist dorsiflexion and tricep strength in this patient was full. This is the standard things that we examine in the child with brachial plexus.
So now the question is, when the C5-6 elements are absent at 3 months, at 4 months, the people who are into brachial plexus practice, Alain Gilbert from France, who is considered as Bhishma Pitama of this, so they consider nerve surgery if elbow flexion is not there at 3 months. And here the child is 4 months old, and we are more inclined that this child would end up with surgery because there might be a neuroma in C5-6 which is not conducting well. Then there was a paper from Peter Waters which we would discuss that they found that waiting for 6 months recovers the biceps in about 60% of patients. So our practice is now that we tend to wait if there is gradual improvement in C5-6 recruited muscles. For instance, if abduction is 1 at this point and a child comes at 5 months and it shows 3 out of 7, or child shows some degree of gravity eliminated elbow flexion, and we feel the contractions in this muscle, then this C5-6 is improving, and then we can wait further. But if it is the same, if it is plateauing over 4 months, 5 months, 6 months, then we go and intervene. The purpose of presenting this case is to what is importance of orthopedic examination, because the static examination shows that passive range is significantly reduced to +10. And we know that when passive external rotation goes below the 40 degrees, this is suggestive of posterior subluxation of shoulder. And along with these two signs, short arm segment and deep anterior crease, they should alarm us that although whatever is going on the neurologic part, there is also something going on the shoulder joint, and then we have to investigate it further. Yeah, so any comments so far based on this, Kapil? How would you take this? this
Yeah,
child?
I think Maulin, those points are very important, which you mentioned, and I think since obstetric brachial plexus is still a little bit of a foreign kind of a area for most orthopedic practitioners, so I think it's all important to be aware of those signs, and especially the flexion crease in the shoulder. I think that's an alarming thing that should point that there's something going wrong. And I think it will warrant further investigation like ultrasound or something to ensure that, what's going on with the humeral head. That's what I would be thinking.
Yeah. So let me go through the case and then we will discuss at the end.
So, as said, so what the dilemma was how to proceed with the further course of management. Should we consider an MRI EMG to diagnose and treat the nerve injury, which is as as Dr. Alain Gilbey's paper says that when biceps has not recovered after 3 months, anti-gravity biceps, if it's absent, then repair will always be feasible. And they had a huge sample size of 1026 plexus reconstructions. Or the other option, that should we wait for further recovery? If we have to wait, then how long do we wait for? And till then, what do we do for the reducing range of external rotation? So this was a paper, as sir mentioned, by Peter Waters in JBJS 1999. And this said that nearly 60% patients could recover after when they observed from 3 to 6 months. So those 60%, we would be avoiding unnecessary nerve surgeries. This was a paper published by Maulin sir in JPO 2022. And this paper highlighted a combination of the diagnostic algorithm for shoulder dislocation. So when the passive external rotation range is less than 20 degrees, like it was in our case, we found that there was no need for a USG as such, and we could actually quite surely say that the shoulder was subluxated posteriorly. And we also use the presence of a deep anterior crease and a short arm segment. So these three elements, passive external rotation, deep anterior crease, and a short arm segment, these three in combination would point towards a shoulder subluxation. So this was so we got the ultrasound done anyway, and we could see that the alpha angle, that is the humeral epiphysis, is lies behind the dorsal scapular line, and the alpha angle is 47 degrees on the right side, which is the affected side, and it's 27 degrees in the non-affected side. This was a paper which highlighted the use of USG for posterior shoulder dislocation. It was published in JBJS 2017, and as we can see, the alpha angle here, it's the line between the dorsal scapular line and a tangent towards the tangent from the humeral head. So alpha angle more than 30 and ossified humeral epiphysis line behind the dorsal scapular line is what decides a shoulder, it's what constitutes a shoulder dislocation. So with this HSC AMS score, the static examination, and a USG that we have now, how would you like to manage the case? So what we performed was we performed a Botox injection in the internal rotators, the subscapularis and the pectoralis major. And this is a usual technique of performing on the left, you can see there are 4 needles going in the subscapularis. We adduct and internal rotate and forward flex the arm so that the scapula is prominent, and then we insert the 4 needles. And on the anterior aspect, we insert 3 needles and into the pectoralis major. So at 3 months of the injection, if we look closely, the shoulder abduction, the shoulder external rotation, and the elbow flexion has now improved to there's anti-gravity movement in all the 3. And in the static examination, the passive external rotation had almost reached full extent. The short arm segment and the deep anterior crease were now absent. At 10 months, there was further recovery in the shoulder abduction, external rotation, and elbow flexion. And the static examination remained the same. The passive external rotation range was maintained. This was our clinical follow-up at 10 months after the surgery, after the Botox injection. The video on the left shows how the child did not have any abduction, external rotation. And the video on the right, we can see that there is both abduction and now external rotation.
Yeah. So, Tushar, the question is whether this is the natural history or Botox aided. So that's a nice question. See, for showing the elevation and external rotation, the glenohumeral joint should be located. Peter Waters have suggested that there is a gradual progressive worsening of glenohumeral deformity if internal rotation contracture is not addressed. In a very latest meeting of Naraka's meeting, Howard Clark, who is the inventor of this cookie test, they found in sick kids that some of the patients with very severe internal rotation contracture, they failed the cookie test and they thought to do the nerve surgery. But when they got an axial MRI, accidentally they found the humeral head was completely dislocated. So, so now their approach had been to reduce or relocate the humeral head first and then see, because in the absence of located glenohumeral joint, it might mislead us that child is not showing good movement in C5-6, but actually it might be because of the dislocated head. So the practice now is to relocate it and then see whether the C5-6 recruited muscles are showing movement or not. We have now a series of about 100 patients where we have done Botox in infantile dislocation. Our approach is we make sure that they have C7 muscles recruited, like means they should have good tricep strength and good wrist extension, because C5-6 and C7, they supply subscapularis. If C7 is not recruited, like if they have wrist dorsiflexion weakness or weak triceps, then it can be a contracted but weak subscapularis. So then we just do close reduction. We have intra-op ultrasound. So once we reduce, we make sure clinically as well as by ultrasound that this glenohumeral joint is reduced. And then we give shoulder spica for 3 weeks. For pure C5-6, we give Botox. Deepak is asking what is the role of Botox in an established contracture. So Deepak, it has been said that once we want to nullify the internal rotator muscle power, as we know that there are a lot of co-contractions between pec major and deltoid, between internal rotators and external rotators. By temporarily denervating them, we allow representation of these external rotators into brain. That's one thing. And we relieve co-contraction. That's the mechanism of action in Botox in OBPP. Unlike in CP, we know that it works only on dynamic contractures. And in static contracture, it doesn't work. The efficacy of Botox is a bit different in OBPP. We want to represent that C5-6 recruited muscle in brain so the child can do these activity. So it's not the natural history, Tushar. We have seen they go on, they don't improve, and they go on complete dislocation. So we have to relocate them by some means. Do you use shoulder spica in all the cases of subluxation? Yes, we do shoulder spica in all. If the C7 is working, then we would Botox and spica. If C7 is not, we will just do the spica. And we follow them in a month's time. Now, if their abduction has not improved at all, or if their internal rotation comes back, then we make decision of doing neuroma excision and nerve grafting. Or if child is older, then we would do a distal nerve transfer, like spinal accessory to suprascapular and now to triceps to axillary and so on. And in older children, we would do tendon transfer. So I hope this is, so the key point why we brought this is, if you might see a lot of patients with non-recovering palsy, and then you directly refer them to plastics. The plastic colleagues would do nerve surgery, but we are seeing a lot of nerve surgery patients not improving because their shoulders are still subluxated even after nerve surgery. So being an orthopedic surgeon, we can check for short arm segment, deep anterior crease. And if passive external rotation is less than 40 degrees, you may advise an ultrasound. And if ultrasound fulfills the posterior dislocation criteria, then it is our job first to relocate the joint. Doing Botox is very easy, and we will share the technique video. So once we relocate it, then we should decide about whether nerve surgery is required or not. The best thing would be to work in a team where our plexus surgeon, orthopedic surgeon, we all are together, and then you will see the outcome. So that was the message. Let's move on to the final case, and that's the most interesting, I think. And Kapil and Rudra, you would love it.
We had a 14-year-old girl with spastic diplegic cerebral palsy functioning at GMFCS 4. She had a progressive crouch gait and bilateral distal femur extension osteotomy was done, and patellar tendon plication were done bilaterally. Here the patellar tendon was wounded around the artery forceps and sutured. We haven't cut it or done anything, just wounded around it and plicated. 2.5 months post-surgery, during rehabilitative physiotherapy, there was a sudden snap which was heard. She was in prone position, and the physiotherapist was trying to improve her knee flexion in prone position. A sudden snap was heard, and it was followed by excruciating pain in the left knee. She was sent to the hospital, and on examination, there was a palpable gap in the infrapatellar region in the mid-substance of the tendon. The child was not able to do straight leg raising, and she was not able to bear weight on the affected limb. We went ahead and we did an MRI. The MRI showed complete tear of the patellar tendon, and that was at the previous surgical plication site. So
just Goda, stop there. So Kapil or Rudra, have you experienced this anytime? This is almost 2.5 months old. Probably our therapist colleague was a bit overzealous, and they were doing kind of high kneeling activities because child's truncal strength was not good. And suddenly child had sneezing, and their core control is not great, and there was sudden snapping sound. So have you experienced this anytime, Kapil?
So not in a spastic, Maulin, I've never had this, but in another child, I've had one. Smaller child, they were trying to flex the knee, child was syndromic, and there was a physeal separation. This is an older child, and it's a patellar tendon tear. So no personal experience of this.
Rudra, you have any such similar experience, or anyone in the group? Yeah.
Even I have not seen such a case of spontaneous rupture. And I mean, what about the way of tendon suturing? Are we blaming that or the physiotherapy?
Yeah. So like we have done now more than 100 patellar plication since, we have been doing since the 2009-10. And how we do it is that earlier on we used to cut it vertically and and then over breast, double breasting. Then we with Dhiren Bhai, and we came to know that the techniques where you don't have to cut the patellar tendon, because if anything happens post-operative, so we just put an artery forceps over it. If for instance this is patellar tendon, we put an artery forceps and then we twist it. So there will be double breasting. Without cutting the course of tendon, we kind of plicate it. So it's a double breasting or triple breasting at times. And that's how someone would push on the patella from the top. So that is a technique we have been using with good result. The patients who are skeletally mature, then we distalize the tubercle, tibial tubercle. That's a technique. Then we shared this case with Kirk Graham also, and Dr. Brunner through Dhirenbhai, and we found that Kirk Graham group, they have published an article for physiotherapists to how to rehabilitate crouch patients, and they might have experienced, he said that they have never experienced this, but there are some reports of proximal quadricep muscle rupture, then tibial tubercle avulsion they have found in few cases. And then they have mentioned that the knee should not be bent more than 90 degrees till 1 year of patellar plication surgery. There's a wonderful paper, we'll share it with you. And here, when the patient, the usual way to improve core strength is to make patients sit at 90 degrees on their knees and to shift the weights. So that's how they work on their trunk. So there's a message that they should not do this in patients who have undergone patellar plication, because sudden jerk or child's movement for to and fro can lead to the tear. Now the suture material we use is 1 number Vicryl, and that's the needle size, and we take typically four stitches. So this is how do you stitch them? What suture material you use, Rudra? Kapil?
Yeah, so I'd typically take the ethibond, like a fat ethibond, like a 5, and typically take those Krakow stitches, and then take them through the proximal and the distal, and then just tie them up.
Yeah.
And I'll probably also take a wire loop around the patella and put it through the tibia, just for additional protection.
So the SS wire loop?
SS wire or a fiber tape, whatever works for you. Yeah.
So we have not been using fiber tape. Rudra, what is your practice? Do you use SS wire?
Sure. Yeah, a couple of things to discuss. One is, I know that the physiotherapy to be blamed. Another thing, parallelly, we have to think that if there is any rectus contracture and it was tight and they were trying to force it, number one, which probably might have missed it. I'm not in this case. Yeah. Number two is, nutrition wise, if there is any gross deficiency of some things like vitamin D and C, I don't know how far they, because quite often the CP children are on anti-epileptic drugs sometimes, and then they have nutritional issues because of oral and other things. And if there is any nutritional issue that has to be addressed, number two. Number three, with respect to the repair, earlier I used to use ethibond suture because it was strong, but now because I've got more experience in the arthroscopy field, so I tend to use the fiber wire or a tape, especially nowadays for repairs. We get even the fiber wires which are used for meniscal repair like 0. So they're quite 0.2. They're quite fine sutures, and they give you very good strength, and you can go through the fibers of this ligament and nicely repair it. So that's what I do. And only thing is, in this case, probably I tend to augment with a tendon graft because it's a rupture what we're talking. Yeah. So I tend to use a tendon graft probably in the same incision, take as gracilis, and then augment it along with the repair.
Yeah. So Goda, can you show the picture of open with the surgery? Because it was very frayed, and margins were apart.
Yes.
And it would, even after doing hyperextension, it was difficult to oppose it absolutely anatomically. So let's Goda run through the case.
This is the intraoperative picture, and the tendons were about 2 centimeters apart with frayed proximal and distal margins. So how to manage this case now? what are the various augmentation and reinforcement options. And so generally autografts, allografts, hamstring tendons, Achilles tendon, and allografts from tissue banks are used. Fascia lata autografts were also used rarely. So what we have done in this case is the free ends were dissected on either side. Another incision was taken on the lateral aspect of distal femur to harvest fascia lata. So we have used non-vascularized fascia lata for augmentation. A 10 to 4 centimeter long strip of fascia lata was taken. It was divided into 3 strips of about 3 centimeters each. Each strip was passed to the substance of the patellar tendon from proximal end to distal end, and reinforcing sutures were taken. 3 of such strips were augmented, one on medial, lateral, and central part of the tendon. So this is a paper which showed a vascularized fascia lata, but here in our case, we used a non-vascularized fascia lata. But fascia lata has its own reliable vascular supply, and it can be harvested either as a vascularized fascia or non-vascularized. They have advantage of the structural properties being similar to native tendon tissue. So this is after 1 year of follow-up. There's no visible gap in the tendon course. The child is able to do active SLR, and the ultrasound, she had little claustrophobia, so we didn't take her for MRI. We confirmed it with ultrasound, and the ultrasound confirmed good continuity of the tendon. There's a continuity of the tendon. And this is her latest gait video. She's doing well now.
She was GMFCS 4. So our goal of treatment was to just make her upright and move in-house for, shifting weight. And that was our goal.
And she's able to do good functional range of movements of the knee.
So this is with weight cuffs, and we are trying to strengthen it. And she can, she can stand independently, and this has healed well. And we have sent this case report in JBJS case connector, and let's see if it gets accepted. Tashwin is asking the video of tensor fascia lata. I'll have to check. I did this case with my plastic surgeon colleague, and they use tensor fascia lata grafts for tendo-Achilles rupture. The atrophic ruptures. And so we used the similar technique for patellar tendon rupture. We did not use any fiber tape, but we relied on the tensor fascia lata. And as you can see in the result, the child can now do full extension again. So that works probably. Yeah. So we have overpassed 5 minutes. Thanks, Goda, for lovely presentation and the literature review. So any final comment, Rudra, Kapil, and Dr. Sriram sir, and then we'll close the meeting.
Very nice cases, Maulin. I think all the cases were excellent, especially the abscess case. I really have not seen like that, and even this brachial plexus palsy was a good message. And all the cases were very nice, so well discussed.
Yeah, so they were interesting ones. Thank you very much. Kapil?
Right. Yeah, I totally agree. Interesting cases and great discussion, and I think we all learned something. So it's a good experience to be here. Yeah.
And what I think is Rudra and Kapil, we can do a monthly meeting where you present at least one case a month, which would be odd and which would be learning for us. In regular fellows teaching, we see common things, but for practicing pediatric orthopedic surgeons for years now, if we share atypical cases we come across, that can help in exchange. So maybe from next month, we all should contribute one case, and then we'll learn from it. Your fellows can present, and then maybe we can arrange a meeting monthly or twice a month. Once or 2 monthly basis, and then we can have those cases. Dr. Sriram are you here or? Dr. Sriram was to part, but he was not keeping well. So he said, Maulin, I will just be around. But yeah, anyway, so thank you very much, everyone. And Tashveen, we will send the papers. Dr. Goda and me would share those papers. Thank you very much, Kapil and
Right.
Rudra.
Thank you. Bye-bye.
Take care.
Thank you, Maulin.
Hey,
Happy
bye-bye.
weekend to all. Bye-bye.
Thank you. Bye-bye.
Bye,
Thank you, sir.
Yeah.